if you were to design the sort of perfect storm of disparity, we would find that in cancer, and in particular multiple myeloma, where as a more rare cancer, there isn't as much understanding and experience of it within the general medical oncology community.
Welcome to another episode of Cobb Company, the podcast of the W. Montague Cobb Health Institute. My name is Rolf Taylor. I am the producer for this series. Over the coming months, we'll be featuring thought leaders in areas such as health equity and initiatives such as increasing diversity in the healthcare workforce and initiatives increasing diversity in clinical trials. We're at the National Medical Association Annual Assembly in New Orleans. I'm joined by Dr. Joseph Mikhael, Chief Medical Officer of the International Myeloma Foundation, and he's going to be speaking a little later today at the Jane Cook-Wright Cancer Disparities Symposium. I'm sure we'll talk about that. So welcome to the podcast, Dr. Mikhael.
Oh, it's such a pleasure to join you today, Rolf. Thank you.
And I'd like to share with our listeners just a little bit of background to get you up to speed. Dr. Mikhael is a professor in the Applied Cancer Research and Drug Discovery Division at the Translational Genomics Research Institute, which is TGen for short, and that's an affiliate of the City of Hope Cancer Center. The Cancer Center, I believe, is in Phoenix, Arizona, and you're based in Scottsdale, Arizona, correct?
Correct. TGen is in Phoenix. The City of Hope Cancer Center is in Los Angeles.
And Dr. Mikhael is also chair of the Diversity, Equity, and Inclusion Council at TGen, so I'm sure we'll talk about that as well. And I just want to make a quick disclaimer. This is a discussion about disparities and health equity, looking at multiple myeloma specifically, but we're not going to dig into the intricacies of oncology and genomics too much. We might touch lightly on the science, right?
Sounds good.
And as I mentioned, Dr. Mikhael is also Chief Medical Officer of the International Myeloma Foundation and Director of Myeloma Research at Honor Health Research Institute. So I think it's safe to say we have one of the world's leading experts on myeloma and myeloma research with us today, and with a DEI perspective. So, Dr. Mikhael, perhaps we can start off with a kind of myeloma 101 for our listeners. It's not one of the conditions that immediately gets talked about in the context of health disparities. So a quick 101 would be who's affected, who's disproportionately impacted, what are the consequences of that, and maybe some similar or related conditions that people are familiar with. I'd also like just to touch on why the genomics aspect is so important.
Absolutely. No, you're very right. I mean, multiple myeloma accounts for really only about 1 to 2% of all cancers, so it is often neglected, although I'm going to make the case that within the African American community, it is the most disparate of all the cancers, in that survival, sadly, is half that of what we see in the white population with the same disease. But just as a quick recap, multiple myeloma is a cancer, a blood cancer, of course, so thought of in the family of leukemia and lymphoma and myeloma, that originates in what's called the plasma cell in the bone marrow. So the plasma cell is the one that makes our antibodies. So even though you haven't been thinking much about plasma cells over the course of the pandemic, we've all been talking about them, because these are the things that respond when we get a vaccination to produce the antibodies to protect us against viruses and various other infections. Multiple myeloma is the product of when those plasma cells become cancerous. So now, instead of producing good antibodies that protect us, now they produce bad antibodies, as it were. We often call them monoclonal antibodies, just referring to their malignant potential. They're monoclonal, and so they can damage the body. In particular, it affects the kidneys, it affects the bone, and then the whole functioning of the bone marrow and the immune system. So patients typically present with some kidney dysfunction, or with bone damage, or with anemia or low red blood cell count because their bone marrow is not functioning well, and very often with infections because their immune system is impaired. So this is a disease that historically, has been thought of sort of almost like a geriatric condition because the average age of diagnosis is around 69 or 70. But interestingly, it is diagnosed 5 years younger within the African American population and about 6 years younger in the Hispanic American population.
And that's not an unusual pattern when it comes to disparities. Earlier in life presentation of a number of conditions is part of what it makes up the health disparities.
Absolutely. And in fact, this is where myeloma really is quite prominent in that realm, not only because of the younger age of presentation, but of the increased incidence of the presentation. So the incidence of myeloma is twice as high in those of African descent, like myself. And we've actually traced this back indeed to Africa. So we've done studies in Ghana and many other countries in Africa that have demonstrated this increased incidence. And although myeloma is rare, interestingly, and I don't want us to get off on too far of a tangent, but the precursor to myeloma, or so the pre-myeloma condition, something we call MGUS, or monoclonal gammopathy of undetermined significance. That just means that someone has a little bit of this bad antibody, but not enough to really have myeloma, is actually incredibly common in 5% of all people over the age of 40, and maybe 10% of all people over the age of 40 of African descent. So the precursor condition is common, but the actual myeloma itself is not that common, albeit, as I mentioned, higher incidence within the African American population. And so the other feature I think that's important to mention that you asked about with respect to the genetics and genomic part, obviously working at a genomic research institute, it's an area of interest of mine. We don't have a simple, if you will, genetic pattern to myeloma in the way that it's transmitted, but we do evaluate the genes of those plasma cells to note the kinds of mutations and the kinds of abnormalities that have developed in that patient to unfortunately develop their multiple myeloma.
And does that help you develop targets for treatment if you have that detailed understanding?
Absolutely. So the value of that genomic testing is really twofold. One, from a, if you will, diagnostic and prognostic standpoint, meaning we know that there's certain things that are so-called higher risk cytogenetics versus standard risk cytogenetics, but then some of them are indeed also targetable so that we can develop specific treatments for certain kinds. And this is actually particularly relevant to the discussion because when we see such, as I'll describe shortly, inferior outcomes in myeloma within the African American population, the natural inclination is to say, oh, well, maybe the disease is just biologically more aggressive in that population, which we do see in some other cancers like prostate cancer. But actually the opposite is true. Black patients with myeloma are less likely to have the high-risk cytogenetics and are more likely to have the lower-risk cytogenetics. And one of them in particular, something we call translocation 1114, is one of those targetable pathways where now we've developed a drug that is specific to that pathway. So you would expect, by the biology of the disease, younger age of diagnosis, lower risk in general, that outcomes would be superior within the African American population. But sadly, the numbers are such that right now, a black man with myeloma will live half as long as a white man with myeloma, and same of black women with myeloma when compared to white women with myeloma. So the incidence is twice as high, the diagnosis is made earlier, they have lower risk disease, and yet, unfortunately, mortality is twice as high within that population. So this is where the disparity is not only evident, but perhaps even underestimated by virtue of what one would expect. And lastly on this, what I will comment that really brings it all together for me is that we now have some very large studies, including studies at the VA, where at least theoretically people are treated the same independent of race and ethnicity. When given equal access to treatment, in fact, African American patients have a superior outcome in survival. So it tells us that there is a path to overcoming that disparity, that it is doable. It's not just a function of more aggressive biology. It really is, I believe, a function, as we'll describe, I'm sure, in a moment, of a delayed diagnosis and reduced access.
So we've got delayed diagnosis and reduced access as being key drivers. What about social determinants?
Yeah, absolutely. When I think of the drivers of the disparity, I always start with what I think of as the unfortunate pillars that drive disparities, health disparities in general. Very critical concepts of systemic racism, the design and carry out of the healthcare system, and indeed the social determinants of health. I think of those, that sort of unfortunate trilogy of things that we know significantly impact outcomes. And we know that these are general to health, but are specific even to multiple myeloma, as we've seen with the lack of trust in the system, with the way the healthcare system, really favors certain kinds of treatments. In myeloma, for example, we use a lot of oral therapies that are not nearly as well reimbursed through Medicare or other healthcare, other insurance systems. And so a greater burden relies on the patient. So historically, patients of lower socioeconomic status have less access to ideal myeloma care, and that widens that divide even the more. And then, as you've mentioned, just very specifically, the social determinants of health that are so influential, right down to the zip code, right down to all of those same aspects that we know affect other diseases. So I think of those as being the overarching drivers of the disparity.
Do you think that in the case of cancer treatment, that cancer treatment is particularly vulnerable to those drivers of disparities because it's complex? Often the treatment is a long distance away. Are those some of the factors that are causing these disparities?
Beautifully stated, Rolf. You're absolutely correct. It's sad, but it is the reality that if you were to design the sort of perfect storm of disparity, we would find that in cancer. And in particular, multiple myeloma, where as a more rare cancer, there isn't as much understanding and experience of it within the general medical oncology community. So care in many ways is optimally given in the larger centers that are often geographically distant from where many patients live, and in particular within, let's say, the African American and Hispanic populations, where there may be more rural dwelling. That, as I mentioned before, oral therapies are often given that make it more difficult to obtain insurance. And then, of course, these sort of major interventions that we have in multiple myeloma, two of which in particular, autologous stem cell transplant or bone marrow transplant, and now more recently, these new therapies of CAR T-cell therapy or chimeric antigen receptor T-cell therapy, those really are exclusively done in those very large centers. And so this is an unfortunate setup for that disparity.
Yeah. If you were a patient that could benefit from, let's say, the CAR T therapy, and I know it's extremely expensive, but there are programs out there, right, to get access for at all levels of income to those treatments. But the barrier is going to be getting to the center and knowing about the support programs, presumably.
Exactly. And so access has so many different layers of complexity, but you're absolutely correct. It's not just a function of getting to the city. It is knowing that the program is available, getting a slot, having the consultation with the expert, caring for the family in the background. We've had many of our patients, even locally, frankly, that are less able to access therapies because there isn't transportation, but also because there isn't someone to care for their family. I had a patient really say to me, Doc, if I'm going to be sick, it doesn't just affect me. Nobody in my family's going to eat dinner tonight if I'm not making dinner. And so it's, I think, starting to have an impact, and I'm sure you've experienced this in so many of the interviews you've done. It's making a step back and look at the bigger picture of care and looking at a model that accounts for the whole of the patient, that recognizes their dwelling, their situation in all of its aspect, and what will happen in their treatment in terms of lost income, in the impact on their family, and the impact really in their community. And it's forcing us to start thinking of models that account for that, as opposed to just saying, oh, well, if you show up and you have this and you have this and you have that, oh, well, then we'll give you the treatment.
So you have a very interesting set of jobs, not just one job. How many jobs do you have?
I want to be careful who's listening, but no, I really have three primary. I mean, my main role is I'm the chief medical officer of the International Myeloma Foundation, where I get to do all of this great work in health disparities, both here and all over the planet, in particular in Latin America and North Africa. But secondly, I do have my academic appointment, as you mentioned, at TGen, where we have a lab and where I get to chair the DEI Council. But then I felt it was very important in this role that I continue continue to see patients. And so I still see patients a day a week, and I do clinical trials through the Honor Health Research Institute.
So you're in a kind of unusual and pretty wonderful position in the sense that you can offer solutions at the individual level in terms of treatment, but you're also thinking at an organizational level about solutions that are impacting these disparities. So could you talk a little bit about those solutions and those approaches that you're developing?
Well, it sounds like you could be my agent, Rolf. I mean, this is marvelous. You're so kind the way you describe that I have this unique position.
I could be available. I don't know.
Absolutely. I mean, I have to say it's like nirvana job to me. Like, I really love what I do. I'm particularly passionate about it, not only because of my origins in Africa, but because, I believe, and I know the IMF has always believed in caring for every patient with this disease. And I think you've summarized it so nicely that this is the sort of massive problem, a complex problem that requires a complex solution that has to be looked at an individual level, but also at a greater societal level. I often talk about the three main, if you will, realms of addressing the disparity in the lay community, in the medical community, but also in the corporate and regulatory community. And so we believe, and I believe, that the solution is going to be all players coming together. And very often, not-for-profit organizations that have that credibility, such as the International Myeloma Foundation, has a unique place to bring those players together to look at a solution. I can't fix issues of systemic racism in the healthcare system tomorrow, but I know that I can advocate for critical changes that will ultimately happen, because we need both a short-term and a long-term lens. But looking at those myeloma-specific drivers and looking them in the bigger picture, which, I summarize in the two arms of delayed diagnosis and access to care, that we can address those. And we have to look at solutions that are very specific to those major problems.
So one of the programs you have is called the Empower program. Could you tell us a little bit about that?
Yeah, it's a little play on words. It's capital M-Power, standing for myeloma power, but really it's meant to capture the tagline that we're empowering patients and communities to change the course of myeloma. So what that means is we first recognize that the course of myeloma is entirely inappropriate, that the disparity is dramatic, as we've described, and that we need to change it. And to do so, we want to engage not just patients, but indeed their communities. So the Empower program that we've built is, if you will, a national movement, but also a city-by-city movement, as we explicitly work in different cities. We've worked in Charlotte, in Baltimore, in Atlanta, in New York, and now we're working in Tampa and in Detroit. And in every place, it's really a threefold strategy. And the strategy, I remember because I have each strategy start with the letter E to help me remember it. So it's engage, educate, and enhance. The engagement is the concept of deep community engagement, that we will partner with anybody and everybody to raise general awareness about what myeloma is within the community, because many patients have signs and symptoms, and the signs and symptoms of myeloma tend to be very vague. People don't come in with a sign on their head saying, "Hi, I have myeloma." They come in with fatigue. They come in with a low blood cell count. They come in with pain, so that we can raise that awareness and have people understand the impact. And so we do work with churches, with fraternities, sororities, barbershops. We partner, of course, with the National Medical Association, the Black Nurses Association. So both medical and non-medical, to dive deep into the community to raise awareness. The second E is educate. One of the greatest disparities, as I mentioned, is delayed diagnosis. And so we feel that it's important to target the primary care providers and that front line, if you will, of healthcare workers that are seeing patients with these things so that they can be aware. One example is diabetes. Diabetes has a lot of signs and symptoms that are similar to myeloma. And very often our patients are told, "Oh, that's just your diabetes, that kidney dysfunction you have, or that protein in your urine," when in fact they haven't really thought about myeloma. So
myeloma can really hide behind something like
Absolutely.
Yeah.
That's really well said. Hide behind it. We use big words like confounding, but that's a good way to put it because it really does hide behind. And we have many of our patients said, for 6 months I was told that this was just my diabetes while my myeloma was brewing. The average patient sees their primary care physician 3 times with signs and symptoms consistent with myeloma before the diagnosis is made. That's even longer within the African American and Hispanic American populations. So the E of educate is designed for that. And then lastly, the final E is to enhance. And that's directed at enhancing the care of patients with myeloma and their care partners by reaching out to those who provide care. So understanding culturally sensitive care, reducing those barriers to access, and indeed encouraging clinical trial participation. I think there have been 4 major things in the history of myeloma that have influenced prognosis that also all start with the same letter T. Triplets or 3 drug combinations, transplants or autologous stem cell transplant, clinical trials, and then more recently CAR T-cell therapy. And sadly, we've shown that all 4 have reduced access within the African American community. So if we can look at very explicit strategies for those, we can improve the access to care. And then perhaps lastly, within the enhanced bucket has been this program that we've developed in partnership with the Cobb Institute and the NMA and the student NMA, which is the Medical Students for Health Equity in Myeloma, is built after the amazing Cobb Institute Scholar Program. So they have this program where they really nurture and mentor junior faculty in careers as they pursue an academic career. Here we've gone even earlier and we've taken 12 medical students, many from historical Black colleges and universities, and paired them with a myeloma expert for the last 6 months. And they've worked together on a health disparities project. Anything to do with health disparities in myeloma. We kept the options very broad, and it's been marvelous to see how they've been working on these projects. And those projects will be presented today at the end of the Jane Cook Symposium in a poster session so that they can have a sense of community together and share this information together. And hopefully we can, in the long run, build a generation of healthcare providers, whether they become myeloma doctors or not. Of course, I want them to do myeloma, but whatever they become, that they will be sensitized to health disparities in myeloma and help with the solution.
I think there's a theme that has come up in a number of our podcast episodes when talking about pipeline and healthcare providers coming through that pipeline is that they wouldn't necessarily think of this specialty.
Correct. It's not the first top of mind, but a lot of it is because perhaps they haven't had a chance to appreciate the magnitude of the impact of this disease on the community. I just did a symposium here this morning, and it was remarkable how many individuals came up to me afterward and said, I had an uncle with myeloma. My father had myeloma. One of our nephrologists here just shared with me that her husband sadly died last year of multiple myeloma. And so it may not be initially top of mind, but as the word spreads, people realize that sadly this disease has affected their community. And so we do want to facilitate a way where we can build a deeper generation. As we know, roughly 14% of the population of the United States are of African American descent, and yet only 6% of us are physicians, or represent only 6% of the physician workforce. So I'm hoping these kinds of programs can, in the long run, help the healthcare system in general, but also reduce the disparities in explicit diseases like myeloma.
There's so many fascinating things that you've raised just now. I'm so happy to hear that the program at the Cobb Institute with the scholars has been a model for you, because it just demonstrates that something that you develop, in their case, really for orthopedics, is applicable and scalable in a different area. And that you've been able to build on that model.
I love the way you say that, because it really is scalable. In fact, we've done the program this year as sort of a pilot year, with medical students, obviously focused in myeloma. But we've now already been talking, because it's been going so well, that perhaps we could do a similar kind of program in other healthcare fields. That perhaps we could do this in a nursing program. Perhaps we could do it in a pharmacy program, and to some degree, maybe even a health policy program, which we know could have a significant impact on, one of those realms that is needed to be affected to overcome disparity. So it's remarkable to me how the principle of mentorship and the scholars program that was built by the Cobb Institute didn't just build its own program. I think it's been used as a catalyst and indeed as a model for many other programs. And I really hope that this will inspire others across the country in different capacities in different ways to recognize the value not only of mentorship in general, but of working in the careers of individuals early on. That's where the passion is lit, for things like health disparities, who no matter where they ultimately differentiate into, that they can have an impact where they are.
It's key to think in a generational way. You have to target people knowing that it's going to take 10, 20, 25 years before those people come through into the system.
Absolutely. And one of the things that we're trying to teach them, which is sort of an inherent phenomenon of myeloma, and this is obviously, I'll mention my disclaimer, is that this is a very passionate area of mine. When I did my master's in education, I did my thesis on mentorship. And so to me, this is very important that I use the analogy of the runner who is not only receiving the baton from someone else, but also passing the baton to the next runner, that we build within these programs that sense that they pass that on along as well, even at a medical student level, as they pass it on to the medical students that come up behind them, this principle and this concept of not only the importance of health disparities, but, how we can overcome them. And so I want to not only, if you will, build a single generation of health scholars that are interested in myeloma and interested in health equity, but have them pass that along naturally, that as we do it year after year, that we can hopefully build multiple generations over time.
So in closing, let's just talk a little bit about where we can direct people for further resources, some of the things that you've talked about. If someone wants to learn about the Empower program, where should they go?
Yes, so to learn about myeloma, we always make it simple and send people to myeloma.org. And that's the main hub site for the International Myeloma Foundation. And nested within that will be the Empower program, which is empower.myeloma.org. And at that place, people can see the toolkit that we've created to help people understand if they've never heard of myeloma, or if they have myeloma, or if they know someone with myeloma, where they can see city by city where we're going. They can, if you will, join the national movement and help us to raise greater awareness around myeloma, and indeed to provide resources to those who desperately need it.
And you mentioned earlier that it's so important for clinical trials to have more people participating. Do you need people who have not been diagnosed to participate in trials, or is it really a question of people who've been diagnosed, who are receiving treatment, that those are the people you want to get into studies, and how can they connect?
Right. So my favorite answer to any question pretty much is always all of the above. And so that depending on the study, there are different studies. So when it comes to those already established with myeloma, about 20% of all patients in this country with myeloma are African American, and yet representation in trials has typically been below 5%. And there are lots of reasons for that, and we're trying to address them sequentially. But people can learn more about that from their local doctor, from their local institution. We at the IMF, the International Myeloma Foundation, are building a hub that people with myeloma or their care partners can go to learn what clinical trials are available to them nearby. For those who do not have myeloma, from a screening standpoint, there are ongoing studies. There's something called the PROMISE study, and then there's another study that's very soon to be launched out of Charlotte, North Carolina, where we want to understand the disease better, even in those who haven't had it yet, because so much of what we've learned of myeloma over the years has been based on screening studies in Caucasian population. So again, stay tuned at empower.myeloma.org or just myeloma.org, and these kinds of things will be filtered there so that people can participate, if they wish, in these larger screening studies, even if they do not have myeloma.
Wonderful. Dr. Mikhael, it's been a pleasure to have you join us on the podcast.
And I have to say, Rolf, this has just been an absolute delight. I'm, as you can tell, a little bit passionate about this issue, as I'm sure all of your podcasters have been with you. But I really appreciate the opportunity to share some of this information with you and hopefully to touch those that can make a difference in health disparities. I don't think the world has ever been more attuned to this issue, and I really do think we can make a difference.